Very good morning, everyone, and welcome to day 2 of FICCI Heal. I can see that we are still trickling in, so thank you for everyone who's here in the morning session. We had a wonderful day yesterday, and I must say that the conference itself is very timely in the wake of us going through a lot of change on the healthcare front. Today's session actually in a lot of ways will wrap up some of the points that were discussed yesterday and set the stage for some of the discussions that are going to happen through the day. And today's session actually is constructed in a way that has two important themes. One is the entire conference, if you've noticed, has been designed from a patient's perspective. And I was reading a book last week written by Eric Smith and another Google board member who talked about a very interesting change that is happening subtly, but it's real, where because of information and the internet, actually the power is moving slowly to an individual. It is an individual who can actually now shake an organization, move a country, cause an entire viral spread of information, right? And there is no way in which industries could be immune in the way an individual now has access to it, right? The pure power of information that an individual has in his or her hands makes the decision-making ability of these people and the way they interact with the healthcare system change over the next few years, and we can see that change happening. So that's one perspective, right? The other perspective is today, finance is a commodity, right? What people are looking for is smart capital, right? And what people are looking for is what's the right amount that is needed to really play the business in a way for the future, right? So we've in that way we've constructed this panel, and it's a very august panel. Thank you everyone for being there. I will quickly introduce each one. We have Dr. Dharminder Nagar, who is the MD for Paras Hospitals. And while I do a short introduction now, I think what really Dr. Nagar has managed to do is create a very different healthcare model beyond the completely tier 1 urban area, and that to a profitable, economically viable model. We have Dr. Talwar, who's the medical director for HCL Healthcare, and he is also representing today the patient's voice. Dr. Talwar is a senior orthopedic surgeon. He currently practices as well, while he plays the other industry role. I have on my right Sunil Thakur. Sunil is a director and CEO of Quadria Capital. Quadria is one of the most prolific healthcare-focused investment funds. It's got global scale. It has operations in India as well. And Sunil has not only looked at traditional investments in healthcare, but through another arm of Quadria Capital, Sunil is also looking at how to enable innovation and in disruptive health startups. So I'm sure Sunil will share some of his experiences while he talks about the topic. On my left is my very dear friend Vishal. Vishal, as someone was mentioning in the morning, has gone over to the other side, right? And right from running a hospital, Vishal now is himself a healthcare entrepreneur and an advisor to one of the largest private equity funds, TPG Capital. And Vivek, who runs Healthcare at Home, another very unique health at home model, which has taken care out of the hospital setting, right out to homes for both elderly patients and post-discharge patients. Right. So, with this, I'd like to kick off the session, and I'll invite Vishal to start off with his thoughts. And Vishal, really, you've seen the whole continuum, right, from operating to investments. Where we sit today, and if you can throw it from both a capital provider's perspective and an entrepreneur's perspective, where are the gaps in the value chain from the opportunities that exist?
Sure, Amit. It's a pleasure to be here. Does this work? It works. Okay. Thank you. I didn't know that, Shobha. So I think let's just quickly take a look at number one. We live in very, very interesting times, particularly the way that the entire scenario around us is evolving. You go back a couple of years and see the momentum of private capital, which had sort of backed a lot of companies. If you look at between 2011 and 2017, there's almost to the tune of close to about $2.5 to $3 billion of capital that has gone behind healthcare entities, healthcare enterprises. World over, when you take a look at PE to GDP ratios, in terms of, number one, why does industry grow on the back of private equity, venture cap, is basically because if you go across the world and see, there is a trend which basically guides the PE GDP ratio. Right, and in most of the developed countries, the PE to GDP ratio is somewhere in the region of about 1.3, 1.4%. In India, the PE to GDP ratio has moved steadily from 0.3 to 0.6%. So that means there's still a lot of headroom for future growth. I think what we are now seeing from a perspective of not just capital funding, but what we are now beginning to see is a big trend from the lens that people and companies are not just looking for capital anymore. Every company has gone through this cycle of raising capital and has also gone through the cycle of what really works for that company. And I think what really works for every company is the value creation plan that comes along with the capital. And that, I think, is a big distinction. There was a time when people would turn around and say, okay, give me the funds and don't look back at me. Right? And today, I think everybody is asking that, yes, it's not just the fact that I need my funds for the company's growth, but I also need a lot more input in terms of how I can use that capital in the right way. So the way that, the landscape is changing, and I think what we will see a lot more happening, Amit, is just the same way as the aviation sector went through a massive change on the back of rising fuel prices, on the back of the whole industry worldwide not making any money, right? And on the back of the fact that ultimately the origin of low-cost airlines around the world was on the back of the fact that that industry never was willing to make money or was making money because there was just so much of inflow that was guiding it. I think we're going to see one of those trends hit the Indian healthcare sector. We will need to go back to the drawing board all of a sudden and start thinking about models and innovations that we have sort of never tracked to. Because there was just so much of capital available, growth was looking to be infinite, that everybody felt that, this is the best way for us to go forward. But frankly, I think the trends are showing very, very clearly that the best way forward is not necessarily going to be only the availability of money, but the best way forward is going to be how you're going to be innovating business models to create more value from a consumer perspective, but more than that, from the company's perspective itself.
Absolutely. And if I overlay the patient perspective, and I'll turn over to Dr. Talwar quickly, one of the things which... Sorry. And if I take the patient's perspective on this whole thing around pricing and value creation, one of the trends we see today for the first time is that the patient is trying to compare prices. It has started from comparing prices of medicines as they search through the internet on whether to buy from a 1mg or a Pharmaeasy or NetMeds, but the patient has taken that into the decision making as well. Dr. Talwar, you see hundreds of patients a month, right? And you've been seeing them for decades. How do you see the expectation of a patient changing given whatever is happening in the ecosystem?
Sure, Amit. Just to take a leaf from Vishal said, we are passing through very interesting times, good or bad, regarding what the patient wants now. I think we are all sitting here in this hall is entirely because of the word the patient. And if we really know the needs of what a patient wants, I'm sure we can work out a model. I won't say what changes have happened in the past, but today's patient is looking at a good, robust healthcare system he is looking at, he doesn't say it, but he's looking at an affordable healthcare, and he's looking at, honestly, a system which can deliver him primary healthcare. He's a patient who is wanting the doctor, when he goes for the consult, he's wanting the doctor to not keep him waiting. He's wanting the doctor to give him a good consult time, and he's wanting the doctor to talk to him about prevention. I feel where we all went wrong was one was during our, when the doctors were coming up, they were doing their MBBS and all. One thing lacking was this part where, besides the consult, we always needed to look at the prevention plan, what could be the plan, and they are willing to listen to it and they ask for it. This became very clear to me after I joined HCL Healthcare, and with a passion to develop primary healthcare model. And in the past 2 years, I've seen the inbound calls and the feedbacks we get from patients is entirely linked to what I said. So I think the need of the patient or the demand of the patient is a good consult time, affordable healthcare, and then talking to him about prevention and how can he prevent the disease and how can his family be looked after by that. Now, keeping this in mind, I feel if this can be the base, definitely our other problems get solved in a very big way. And if we start screening people, which we have done in areas where our clinics are located, people are highly amendable now to becoming part of packages, to becoming part of yearly plans, where they themselves and the family are wanting to be screened at regular intervals so that at least the NCDs can be taken care of, and they are willing to get the treatment done by the treating doctor, the doctor who's put the package forward, so that how can he or she be healthy. They are even looking at the doctor and the corporate dealing with healthcare to be able to give them red flags when needed, which was never the case in the past. They are very happy to be able to get mails or messages that this is the time your next test is due. And honestly, a very high percentage, contrary to the belief that the patient will not come and after you've flagged off saying that this is what HbA1c was and now it's 3 months, we told you to get back, majority of them come on their own. But they appreciate if someone can just tell them that next week is your test is due. And they are valuing EMR now. I just want to touch on that. They're valuing that their entire record is with the corporate or is with the stakeholder, is like a record to them, and they sometimes demand us to pass it on to their doctors or their specialists. So I feel that's a big change, and if we understand the need of our patient, which is this patient and his family, I'm sure this model from base to the top can do very well.
That's very well put. That's very well put, Dr. Talwar. I'd like to turn over to Dr. Nagar, and the fantastic thing you did, Dr. Nagar, was take organized, high-quality healthcare beyond the 4-6 metros. That has a unique set of challenges, if I look at it that way, right? It has a very different patient pool. It has a very different lens on the economics of the business. Right? Would you like to share your experience on both the challenges and the opportunity you see in those markets, and especially for capital providers who just about started to look at it?
Morning, everyone. I think there are two myths that have existed in everybody's mind. That if it is a tier 2, tier 3 city, people's expectations are also tier 2 and tier 3. That's not true. Everyone expects the same healthcare that they expect in Delhi or Mumbai. So let's stop pushing second class, third class healthcare to tier 2, tier 3 cities. It won't work. It does not work. The anecdotal evidence I have, the factual evidence I have clearly shows, whether it is Patna or Darbhanga, which is not even tier 3 yet. In fact, if I say Darbhanga, it is probably close to tier 4 or 5. But their expectations are no different. They want exactly the same thing that you are providing them in Delhi. And also on the financing side, I'm honestly telling you, they're willing to pay for it. They want to pay for it. Yes, the pool, if Delhi or Mumbai is 20% of the population or 30% of the population that can afford that kind of healthcare, in these smaller cities it may be 5%, 10%, but still it is huge. So I think we must get away from the fact that if it is tier 2, tier 3, let's give them something secondary environment, let's give them something cheap, let's put a cath lab that doesn't look like a cath lab, it doesn't function like a cath lab. Instead of 5 doctors, let's get away with RMO. It doesn't work. Everybody's expectations are the same, and let's work on that. Number 2, I mean, for me, it's been a successful model. But the population as such in the country today, because we are talking about healthcare financing from a provider perspective is, I think, very well documented. Lots of data, lots of stuff is happening. Everybody's been invested in. I've been invested in recently. We can get access to capital. Whether it is the right capital or whether it is a wrong capital, we can all have a debate about it. But where is the patient? Who's funding him? How is he getting access to finance? And I think there is a huge amount of government role that needs to come in. And I think that is coming in. We were just going through a presentation Niti Aayog has proposed. The government is proposing that within the next 2 years, 40 crore of this country's population will be under some sort of health access scheme. Up to 1 lakh of amount shall be insured. That will be transformative. Even in smaller cities, people will have access to health insurance up to 1 lakh of rupees. And 80% of all the diseases and all the coverage in hospitals comes under that one. There might be exceptions in oncology, cardiology, but with the stent prices going down, I think that may not be exception for too long. So I believe healthcare financing has to be looked at both from the provider perspective as well as the patient perspective. And healthcare financing for the patient, I think this government, this new dispensation is looking to change. And if 40 crore population comes on board with healthcare, access to healthcare, I think providers are there who will provide that healthcare.
Dr. Nagar, one follow-up question, and I'll push the envelope a little here, because the way at least my experience has been, for pure play private capital, hospitals in any case have been a stretched investment. You know, the capital returns, the feasibility compared to other formats is always a question. Now, when you take this model to a setting where the inherent viability or the pricing is at a very different price point, do you think that there needs to be alternate sources created or other financing support that needs to happen to make the model more robust?
You're absolutely right. I completely agree with you. But there aren't. I mean, I must give you an example. I was recently raising capital, and one of the so-called socially active fund showed interest in me. Oh, fantastic job, you're working in tier 2, tier 3, we love you. We have our board members say this is part of our design. But in 2 months' time, they came back to me, sir, I think your Darbhanga thing will not work. I think you will not make money there, therefore we will not invest in it. So let's make up our minds. I mean, are we socially conscious people who are going to give funding to organizations that are going to these cities? Or let's put our hands up and say we'll only give money to people who make 30% EBITDA. I think we have to make up our minds. It does not exist. A lot of people say it. I haven't found guys who are actually willing to put their money where their mouth is. And I think that is the big challenge.
Hi, good morning, everyone. I have a point to add to what Dr. Nagar said. There are pools of capital available which are alternate sources, but I think India as a market is not well oiled enough to move capital from supplier to the demand side. We in one of our investee companies have been going through this model where they have they have a center of excellence. So we've invested in a company called Asian Institute of Gastroenterology. It's supposed to be a referral center world over for gastroenterology diseases. And the way they augment their resources is obviously they have private equity money in, which is going to be used for a particular source, but they are also receiving money from grants, and these grants are mainly going into research activities, and huge grants, and these are all global agencies who who are interested in some of the research that the hospital is doing. And the way the hospital is using this amount is with the clinical pool, and that basically helps the hospital to augment resources to pay to the doctors, and doctors are interested both on the research side to do research as well as obviously to serve the patients. So there are resources available, but as Dr. Nagar said, it's far and few. He's not come across, rightfully so, because it's not easily available. And that is where people like us need to get involved and try and get the supply to the demand. And the activity that Paras is doing in a place like Darbhanga is an ideal place situation for impact funds to come in. An impact fund has a huge capital globally.
So Sunil, just for the benefit of the audience, what is the difference in expectation of returns of impact funds vis-a-vis the traditional private equity?
Well, it's a bit muted, but all the impact funds work with a commercial intent and objective. But compared to a plain vanilla, private equity fund, the expectations are a bit muted.
Right. Okay. Thank you. So I'll turn over to Vivek and also Vishal, if you can comment, because both of you all, Vivek, you to start with, have set up a business which has taken care out of a hospital setting, right? The business is well established in global markets, but for India, it's a very new model. Insurance didn't recognize it. Patients didn't understand it. It was a glorified nurse at home model, whatever it is, right? What challenges did you face, Vishal, in actually putting this story out to investors as you successfully raised the money? If you can walk us through your journey, and Vivek, both of you, and then I'll turn to Sunil. From a capital provider's perspective, how do you look at funding some of these companies?
So you want to go first, Vivek?
Yeah. So I think you're right, Amit, in saying that there were a lot of challenges, and I'm sure Vishal would agree to it in terms of raising capital in a model which is existing across globally, but in different ways and formats, which is very unique to the Indian conditions. We were developing something, and in fact the whole industry is developing something which is unique to India, and it's not a copy paste Amazon to Flipkart model, which is there. So you don't have a very 100% equivalent precedence out there which you can showcase. Look, it has happened in US or in UK or whatever, and hence you should invest in India. And that's how many of our investments in India happen. Copy the model from outside and say that we'll replicate the same thing, and that's where quite a lot of global funds also come in. However, this industry, while exists, had different challenges in India and different issues in India. I think that was the biggest thing. So to explain to people that this is a big space in India, and for them to appreciate that something unique is getting built for India, from India, which is different from globally, and then to showcase that there's in the long run it'll start generating money, and it's a very important alternative to the current healthcare environment, which is largely hospital based. I think Dr. Talwar covered affordable care, and he talked about prevention. He talked about how people are becoming more and more aware. Now all these things are actually working in favor of the home care space. So technology is being used to improve access and to be able to reduce the cost. The cost of ICU in a hospital versus the cost of ICU in a home is about 50%, right? So the cost is decreasing, and you can go to Darbhanga, for example, and set it up one ICU at a time versus setting it up and then raising, capital, etc. And then all these models can help people remain at home, and that can happen through prevention and through managing the diseases on the chronic side, so that people don't reach the the hospitals and you don't load them with the cost which is coming in the hospital. So that was the all these things were it's not easy to explain all this thing when there is no precedence, but luckily for us, we had a partner who understood healthcare very well, and we got the investment because of their in-depth knowledge about this system.
Can I ask you one more question, Viveka? Actually, two. One is, if I'm a patient, how would you quantify an economic benefit to me? Because my options are many, right? And there is a new option you're presenting. And the second is, for a capital provider, a private equity capital provider who's only traditionally looked at very asset-heavy formats, having a very people-driven model becomes inherently a challenge, right? Especially given the Indian market with so much attrition and churn and everything else. So can you shed some light on how these two things, questions have been addressed?
So I think the first one is relatively easier told, but difficult understood, right? So, for example, if you see the global data available, you will see that various studies have shown that about 20%. So home care is about 20% cheaper than the hospital. Globally proven data is available. But if you see a like-to-like comparison, and this we have done for insurance, etc. I just told you the ICU at home, like-to-like versus a corporate hospital would be about 50% cheaper. Oncology, chemotherapy at home would probably be 20% cheaper. This is like-to-like. I'm not adding the cost of travel, the time lost of the individuals who are going alongside with the patient. All that is additional benefit over and above. This is like-to-like. And then if you go and are able to manage chronic diseases, then you're saving a lot of money. So I was giving an example yesterday. Let's say a chronic disease management program costs you 1,000 rupees in diabetes, right? 12,000 rupees a year. If you are able to, if you're able to push, let's say, the cardiac event which will happen because of diabetes for 10 years, you're basically paying 1.2 lakh. Otherwise, you would have done a surgery which is double the cost. So saving there again. So those are the costs which are we can quantify. It's just that for the customer to understand prevention in India is a tougher challenge. Indian society is low on insurance because they don't understand prevention that well.
Actually, prevention is tough to understand globally. Yeah.
Correct.
Yeah.
So let me, give it a little bit of a different angle on it, because, in all my 25, 26 years of running hospitals, two metrics keep hounding you each time, right? And these two metrics are average length of stay and average revenue per occupied bed. Now, if you just go back into this sector for the last couple of years and see how much expansion has really happened in terms of new infrastructure creation, in terms of number of new beds that have got added in this country. Obviously, we all keep talking endlessly about the demand-supply gap, but the fact of the matter is that every additional bed that we are creating today is costing anywhere between 75 lakhs to 1 crore rupees, given the real estate costs and everything that goes with it. So now just go back into the whole economics of the game and say that, if this is the amount of capital that is going to go behind infrastructure creation, then what would you rather do? Would you rather optimize utilization of current infrastructure, or continue to create more infrastructure but having completely zero ROIC returns? Right? And that, I think, forms the basis of any new innovation in the way that India needs to receive its healthcare. Because if we keep following the same game, I don't think that, and while we all have tons of capital to deploy, but I think at the end of the day, it's also about capital doesn't come free.
Yeah.
Right? There has to be a return of capital for everybody. And so I think from that context, if you take a look at home healthcare, and so, at Medwell Ventures, I've taken now 2 rounds of funding, and one with Fidelity, the other one with Mahindra Partners, and we've now raised close to about $35 million of actual capital behind the company and not just something that is going to happen in the future. So I think that the biggest driver for all that was the fact that if you can keep people at home and you can create a cost advantage to them, given the fact that yes, hospitals are going to get filled up and more hospitals are going to get more and more intense in terms of their medical treatment. And what would hospitals want to occupy themselves with? Surgical intervention, life and death intervention, and intervention of just very, very high intense care. And if we were to then skin out of that patients who actually occupy beds for transfusion medicine and just routine daycare work, why would you want them inside your beds? And if you then just apply that logic and turn around and say, where else can these patients be treated? Can they be treated in outpatient settings? Can they be treated at home? Can they be treated in other healthcare environments where the cost of care is not very intense? I think that's what then creates the logic of providing healthcare services at home. And yes, it's not going to be easy because capital and intensity of people requirement for these kind of businesses is very, very intense, and people are getting more and more short supply in spite of us being a 1.3 billion people country. So I think what we really have got to do is to see as to how technology and people can match up as you start providing care outside of the hospital setting. And that truly is going to be the way forward.
Right.
Amit, can I just make a comment?
Yes.
I think we all sitting on this panel are talking the same language. I think we are on the same page. What Vishal said, Vishal being in the IPD side for the past 25, 26 years, we at HCL are now collaborating for home care too in our OPD model. And I was talking to Vivek just an hour back on this. And if you see what Dr. Nagar just said, is that if Niti Aayog is thinking of getting 40 crore people under the gambit of 1 lakh of this, I would be very, very happy to suggest something, I wouldn't say better, but something easily doable would be at half the cost, or maybe 20,000 rupees a family, you could get 80 CR people under the gambit. And I'm talking of a business model which we have our model in place where we see at a family plan for each family of 6 to 8 people paying us just little in excess of 15,000 a year to be able to screen them, to be able to get their entire family on that prevention role we are talking of. I think it's a no-brainer. I think we all are talking the same thing, but how to get it, the perspective clear, or how to get it on ground is what is needed. A few heads coming together. And I think we should give it a very strong social impact that this is a doable model. And if I can spend, instead of 1 lakh of rupees per person, if I can spend 20,000 rupees for a family of 4 or 6 and be able to screen them and to be able to tell them what to do and not to do, I will have, as Vishal says, very few people visiting hospitals when needed, and incorporate a healthcare at home model with it would further decrease the numbers. Because people in general, when Amit spoke to me about this panel, and I am in touch with people as patients, as one-to-one, not just in orthopedics, I'm talking of primary healthcare patients, people are not willing to go to hospitals for simple things. The echo is that we would rather go to somewhere close by, 1, distance, and number 2, I'm going to get lost in a hospital for a simple thing like even for a dialysis. They're looking at, they're asking us, they're looking at places which could do affordable dialysis in the neighborhood or in an outpatient setting or a setting. So I think it's just a matter of few heads getting together, charged with a passion and a mission, and I'm sure, Amit, this is a very doable model even for the government, and I'm sure a lot of private players will get into it, because what we have on our side in this country is volumes. So you can't go wrong.
But let me ask you a provocative, and Sunil, I'll come to you. From a patient's perspective, how ready is he or she to give up the comfort of moving out of the hospital? And who's driving that decision today?
See, when we get our regular suggestions from people, we talk to them, we try and attend. Every patient who walks into the clinic definitely gives a feedback. That's one of the kind of KPIs, or one of the things which has been passed on to us by the Johns Hopkins, is that you have to have a feedback any which way in 48 hours. So what we get out of them, and when we talk to them, is that we are at a stage today, I can boast about it and say it very clearly, we are at a stage when the patients are wanting to give up the hospital setup for things like consults, for diagnostics, for examinations, the blood examinations, for labs. They're not willing to go to hospitals. They use a very simple term, which I'm using it again, is that we get lost. We have to go to multiple counters, we have to wait. And now even an average patient is not, Amit, wanting to wait beyond a norm. He's wanting a non-waiting, he's wanting a very good consult. And last, he wants to talk to a care coordinator. He wants to be talked to about prevention and care. So I think we are at a junction today, we are at a time, as Vishal said, that we are at a very interesting time, and we have to capture it. It can't just end with a feedback. It has to be captured by people like us and go to them and say, this is what we can get you in an out-of-hospital setting at this affordable cost. And I'm sure there are large volumes of patients and families, let's not call them patients, families wanting to register on these loyalty plans, family plans, to be screened.
So Amit, let me make a direct statement over here. I think the biggest change agent is going to be the clinical behavior. I think if we don't go down that path, and as we can see, regulatory forces are going to, number one, change clinical behavior, but that's more being directed. But I think until and unless clinical behavior changes in terms of adapting and adopting these new models of care, it's only then that we will see this larger agenda around affordable care actually becoming a reality. Because till the time clinicians don't turn around and say, I believe that you are going to be treated more affordably outside this setting where I sit right now, it is only then that you're going to actually find that consumers are also going to embrace the same concept. Otherwise, what is happening right now, and rightly so, we are going to take the long path of changing consumer behavior, right, and directing the change through consumer behavior, right? And this is very much akin to what is happening in the e-commerce world, that you're going to put millions and billions of dollars to work to basically change consumer behavior pattern and consumer purchasing pattern. But if we simultaneously do not change and do not adapt to the change that the clinicians need to drive, I think sooner or later the change is going to come, but it's much better if the clinical behavior changes simultaneously.
Oh, absolutely. Sunil, you've done the host of investments across both asset-heavy formats and with Health Quad, which is your digital health and innovation platform, even technology-enabled formats. So I'm going to ask you another direct question here. I mean, we've had several voices coming, both from patient side and from the entrepreneur side. Now, from the place where you sit, what are your factors of evaluating a business, and especially a technology-driven business as it sits today, which is trying to disrupt a traditional healthcare model?
So, Amit, the way, so I wear two hats. I look at the growth capital, which is more traditional model investment format, and then also Health Quad, which is our venture arm, where we do mainly technology-driven platforms. So the way we see the technology side of the business, that it's more urban-centric model. So far, we've not come across any scalable, prominent technology models that are going to cater to the rural market, and mainly because we feel that the supply side needs to be sorted out, because technology, when you talk about rural sector, is a proxy for hard infrastructure and human resource. Human resource has not been sorted out yet, and unless that is done, I don't think we will have any successful models on the technology side playing out in the rural market. While we are seeing some, moonshots, but I guess it's far away. So technology side for us is limited to the urban center. It's to do with things like e-commerce. The pharmacy, I can club it as e-commerce model. It's got to do with home healthcare models where we've invested, but we've invested from the growth capital side. It's got to do with the empowerment, so do-it-yourself kind of models, consumer empowerment models, which are more information-driven. Then you have data analytics. All of this is more or less urban-centric models. What we would like to see are models that are basically going to drive, the rural side of healthcare sector, and that's a volume near 70% of the population. So we are still waiting for that model to come out, but I guess it's still some time away. When we talk about the growth capital, we still feel that the traditional model still has good potential, but on the services side, it's going through the turmoil, and what Vishal mentioned, that unless again the supply side is not sorted out and Clinical Establishment Act or the clinical side is very, very important, I feel that the attractiveness on the traditional format, at least for the next 2-3 years, is going to wane out. People are now moving to the sidelines and waiting for the regulatory side to be very clear about what the government feels for the sector.
So Sunil, just on that point, as a capital provider, and maybe this is a question for Vishal as well, what are the top 2 or 3 risks you see from the Indian market in healthcare?
Well, the regulatory is certainly the biggest challenge that we see, and secondly, government's action on the supply side. So when we invest in hospitals, I can tell you we're least concerned about the infrastructure side. That's sorted out. And to answer the point that you made in your earlier comment regarding human resource, that's very, very important. And we feel that unless that is sorted out, I don't think healthcare models are going to be successful. So things like supply on the nursing, paramedics, on the doctors, we're running short of that human resource. So it's regulatory mainly, and then the human resource. So these are 2 big risk areas that we see when we make investments.
So Amit, I think from my perspective, one of the big issues that I see in the Indian healthcare space is that we have still not become professional enough. Right? So while we are all very eager to take private capital, while we all are very eager to take venture capital and also private equity capital, but if you look at all that has happened around us, there is still a massive lack of managerial talent in this sector. Right? And that, to my mind, is one of the biggest hurdles and roadblocks that you face, because ultimately, when you're backing companies for growth, when you're backing companies for exponential growth, you also want to make sure that you see in front of you people who are going to really make that happen, right? And I think besides a couple of chains and companies that have sort of done that, there is still a big gap that I see which needs to get filled. I think the second one, which is which is also now beginning to play out a lot more, and I'm sure Sunil would agree with me, the Indian market has been hugely overheated with valuations. Right, and this whole thing around that the future is endless for us, and so therefore, one will continue to see so much of growth happen, and it was on account of that all the companies have, whether listed or unlisted, have been sitting on massive forward PEs. I think we are going to see a slow and gradual reality coming back into the sector, because many of the companies have actually not tracked to their valuations at all. And I think that's scary in one way, because it just then takes capital away for some time and wait for sanity to come in. But I think we need that sanity to come in, because ultimately, and I'm sure that's the next part of your question, where are exits going to come from? Right? Because if you are going to have so much of forward-looking opportunity, and you don't see early roots of that and shoots of that in terms of what we are seeing on an annualized basis, where are we going to head with all this, right? So I think that's something which is very important, and that's why I keep on saying again and again that we need to professionalize Indian healthcare a lot more than where it is right now, in order to get a lot more external talent to come inside this sector and make its growth happen and make professionalism happen, so that then you can also create more accountability.
Right. So let me ask the entrepreneurs and the businessmen this question. So to Vishal's point on bringing in professional talent, and especially talent now from outside of healthcare, what's been your experience, Vivek, Dr. Nagar, Naveen?
I think I completely agree with what Vishal has said, except that the valuations are overheated, the future is not going to be so bright. I don't agree. I mean, future is going to be bright, but it might not be bright for the people who only want to serve 1% of the population in Delhi and Mumbai. I think that is the whole gap. We are still not touching 80% to 90% of the population. And we are saying we are kind of filled out, there is overcapacity. Yes, there is overcapacity. If everybody wants to build a hospital in Gurgaon, of course there is overcapacity. If nobody wants to travel 100 kilometers further from Gurgaon, then of course there is an issue. So we have to challenge ourselves to search for different models and impact and make an impact in different models. We can't all be chasing the same two guys. Impact funds chase the same two guys. The PE guys chase the same two guys. Everybody's chasing the same two guys. We will have to figure out different models. We'll have to figure out different leaderships and people who are doing something different in areas where access has not been there. And affordability, yes, Dr. Tarwal, you mentioned everybody wants affordable healthcare. I think everybody wants free healthcare. Nobody wants affordable healthcare. They'll just barely tolerate affordable healthcare. But I think there'll be a huge amount of backlash against expensive healthcare. I think that is the reality.
So you didn't answer the second part of my question.
So
which
Amit, I'll probably take the second part of the question on talent, which I completely agree with Vishal on that. As an example, out of the 12, 13 people who are in the senior leadership team for our company, only 2 come from healthcare. Everyone else is from outside of healthcare, whether it's the HR, whether it's technology, whether it is finance, whether it's anyone else. Everyone is coming from outside of healthcare because the talent there is short, and if you continue to look at talent at that small pool of hospitals, etc., then like valuations, the value of salaries also continue to go high. So you will have to have talent from outside who have seen scaled innovative businesses, innovative people capabilities, technology capabilities, which has not been the greatest of thing for the healthcare industry, and get those outside learnings to improve the healthcare ecosystem in India.
So I'll ask a very provocative question to both the investors. So if you had one entrepreneur who's a great doctor who comes in with an idea which is maybe a Me Too idea, and a non-medical professional with a great healthcare idea, how would you evaluate both of them?
That's a real spot, right? I think number one, the idea is the one which merits funding, right? And number 2 is the execution of the idea, which can actually take the right utilization of that capital. And whether it's a clinician or it's a non-clinician, if you find that the execution is going to happen, then you will fund it, because you basically like the idea. I think what we lack, and that's why I keep making these provocative statements all the time, because we can go round and round the bend every time and keep sitting here and conceptualizing the same thing. But until and unless we embrace change in this sector, it is not going to change. And it has not changed for a very, very long time. So what we are seeing now, which are the forces of change, it's again because it's being thrust upon us. So I think it's important to sort of, look outside and see. And that's the reason why, Amit, at the end of the day, and, while we may turn around and say many of these venture capital funded models don't really work because they are not showing any roots of profitability in the long haul. But the fact of the matter is that there is billions of dollars of capital that has gone behind, not just everything, but even healthcare technology over the last couple of years. And why has that happened? Because that is what is really going to drive the change. So I think ultimately it's all about whether the idea in the short and the long run is eventually going to make the change happen. And obviously profitability is a key component of it, because if beyond a point you're not going to be profitable, then why do you exist?
I completely agree with Vishal. It's a no-brainer, in fact, that a good idea will always get the funding, because you don't need to be a doctor to run a successful healthcare service model. Clinical capability is just one component of the entire value chain when you talk about healthcare services. So doctor just provides one component of the value chain. You need a smart manager and a smart leader.
Can I just disagree here? I'm opening up my hospital for all the IITians and MBAs who go sit in private equity and investment banking to come join healthcare on the operation side. Most welcome. And I don't see too many of them running and chasing me for the jobs.
Sir, I'm there.
And one more thing, Amit, when we talk about clinicians and clinical and the non-clinical side, we were, before the panel started, talking amongst ourselves, and which even Vishal brought it up, the soft skills of the doctor. And when I, with a passion, get up and say that the primary healthcare model is what is the need of the hour, both for the private and the government sector, I'm looking at a doctor being able to satisfy a patient to the point of prevention and care. It cannot end, a sore throat cannot end with an augmentin and that's it. There has to be something else to it. And what happens in a consult room is what is never in the purview of a non-clinical person. And honestly, I started the panel saying that we are here because of the patient. And if our patient's needs are addressed by me or us, and that's where the key to the whole story is. So we have in our setup, just to give an example, we have regular training of our doctors on soft skills by people who deal with it. There are clinicians and non-clinicians telling doctors how to go about it. We have regular trainings, and honestly, it's the time of the GP now. For the kind of setting we're looking at in our country and what we are passing through, we need a trained, a sensitive, and a soft-skilled GP who will deliver this model.
Right, very well said, and I'd like to bring this to a close, but before that, and I turn it over to the audience, to the wonderful panel, any closing remarks for the audience before I turn it over to the audience and ask questions? Any of the panelists want to do any closing remarks?
So let me just, just one sentence. I think, we started the panel, and every day what we are reading in the newspapers is like as if doomsday has come upon this industry. Right, and which is rightly so, because whether it is stents and orthopedic implants, and today it's about medication. I read this morning that the whole NPPA structure is going to go through a massive change because of the whole, this whole issue around medicine pricing and things like that. So I think the next 12 to 16 months are going to be one of massive change. Right, and until and unless we begin to rethink the way that healthcare needs to be delivered, we're going to see a lot more challenge in front of us.
Absolutely.
And that's why, when I talked about that, there are enough industries which have redefined themselves on the back of regulatory change. There are enough industries and enough lessons out there in many other sectors around the world which have sort of learned the hard way that how profitability needs to be made in spite of, lower revenue structure. So I think we really need this time to rethink ourselves and go through a lot of introspection in terms of what models are going to work and what models are not really going to work over the next decade.
Absolutely, and as an industry, I feel.
As an industry, absolutely. It's not about one or two or three players, but I think this is going to be a massive sectoral change which we will face, and it's therefore very, very critical for all of us to sit together and see what we need to rethink together.
Yes. Dr. Lal. Can someone be here with the microphone? Yeah. I think we have a lot of questions across the table.
Yeah, this is Dr. Lal here from Dr. Lal Path Labs. The question is also, I think, maybe this is better. See, the expectations from the point of view of the investors and the expectations, on the ground, there's a big gap. And yesterday only in the opening session, I had pointed out that there are very few hospitals here who are reporting, 15% EBITDA. And about 5% PAT. Not these good ones are 5% PAT, and majority of them are negative PAT. So no investor, at least whom I know, would be interested in this kind of a model. Whether the country is overheated or unheated, that's a separate point. But what the government's aspiration and the people's aspiration is very simple. That 70% of the people are living in non-urban areas, semi-rural or whatever, tier 4 or beyond. And how can they pay? They have no money to pay. I mean, that's the one thing. So no investor, from my point of view, is going to go with you. I mean, HCL is a different example. But if you really want to serve the people, the talent is not available in the rural sector. In fact, the doctors will charge you more. They tell you on your face, we are not going to go there. And the nurses who are absolutely unavailable even in the urban towns. What are you going to do and how are you going to do? So there's a difference, but the main point is the paying capacity. So the aspirations from the investors for India will have to change, and you will have to tell India as a whole that we don't expect more than this. Everybody knows that the hospitals take 7 years, 8 years to break even. A hotel is better, 5 years, etc., etc. Fixed deposit is 6% in any case. So point is, there has to be something which has to come from the financial side. And it is no rocket science. The idea is very simple, that you agree on some kind of a positive growth. Whether that's going to be 2% or 4% is debatable. So that's what I want to say.
So, Doctor, that's exactly the reason why I said that valuations will need to get tempered. Because the growth is going to change, and the growth trajectory is going to change a lot more. And obviously the profitability trajectory is also going to change a lot more. So therefore, the valuations will need to get tempered.
So, sir, if I can answer that question, while obviously there are comments on the valuation, but it's also important, not only for the investors, but also for the entrepreneurs, that there is a proper return on capital. Because even the entrepreneur suffers from that. So if somebody is supposed to invest in a rural setup and deploy capital, and if the return doesn't come, then obviously the entrepreneur also suffers, Investor obviously has to suffer. You picked up two very important points, and that would have been my closing remarks. That as stakeholders, we should try and fix two important things. One is the entire supply side, which is resources. Because unless you have the resources, even if you put a hospital infrastructure, and if people are not ready to go, if you don't have paramedics and nurses in rural sector, we will not be able to offer the services. The cost side the price is a different point, and the second part is on the financing. So in developed markets, governments come forward. Somebody has to take a lead on the financing side, and if Niti Aayog, what they plan to do is to cover 40%, that is going to be one big step. But then the other important step, it has to be the resource side, which is fix the manpower. Once that is in place, automatically we will see the return on capital coming in a positive way, and then obviously both the entrepreneur and the investor are going to meet their objective.
So I think there's one more point, Dr. Lal, on this side. If you look at the cost structure of a hospital from a project basis, it's very different in India compared to different parts of the world. Here we pay a lot more for construction and real estate, which skews the economic viability in itself. And I think it could be from an investor's perspective, and I think, but the other point is one has to even relook on how the model needs to be worked out and agreed with regulators or financing authorities to make sure that the project itself is viable in the first place.
Correct.
The other part to this return is obviously you look at it from both from a balance sheet and from a P&L perspective. Balance sheet obviously because of the cost of real estate, it skews the cost of infrastructure. But even on a P&L, if you actually peel off, you see that there is a huge expense that goes for the manpower, and within the manpower, if you look at the clinical cost, that is huge. And in India, it's a huge skewed cost, and that is what the point that Vishal was trying to make. I think over the next 2 years, everybody has to take this burden of what the government is trying to do. So the expectation adjustment has to happen across the entrepreneur, the investor, and the doctor.
Yeah. Dr. Bagai. No, it's just shown.
Hello. Yeah. Dr. Sanjay Bagai from Manipal Hospital, Dwarka. I think these changes, as far as the government regulation is concerned, will continue to peak till 2019. Okay, that's for obvious reasons. Every day you will see something. Maybe it will not culminate into implementation, but you will keep hearing something which is a feel-good factor for the general public. I think the debate of doctors versus MBAs will continue to rage, so I'll park that aside. Just a couple of points. We've done extensive work on this, so I'll just give my observations. I think telescoping, as far as pricing is concerned, is something which we don't pay too much of attention. We've done that very, very, very fine comb minutely in our hospital, just completed recently with Dilip. And I think to get that right, you will get a lot of formatting correct. Because the difference of delta as far as telescoping versus non-telescoping gives you a margin edge. Second thing is we don't look at lab and radiology as far as profitability is concerned as a standalone business model, which we have done personally. And we tend to depend on lab and radiology as a spillover, as a percentage calculation by a fixed formula, which I think is completely wrong. Lab and radiology is a massive source of income, and there are standalone centers which have proved this. But if you combine this with IPD and OPD, I think it's a complete runaway success. It will give you at least a 1 to 2% difference as far as your bottom line is concerned. Third is the concept of the implants which has come in. I'm sorry, I'm just rattling off a couple of points and anyone can address it. I think implants as far as stents or joints and so on, and now it's going to be intraocular, and I think ultrasound is also going to get a cap soon. This is what I heard through corridors yesterday. I think this is going to take an impact. And I think we need to look at the packages designed a little differently. Some costs will be visible, some costs will be hidden. But I think we need to beat the system and not allow the system to beat us. I'm not in favor of a 300% profitability on implants, but I also need to look at how my bottom line is being met. And lastly, a lot of doctors' packages are going to be relooked very aggressively. And I think sooner the doctors actually understand themselves, that an 8 crore package is a non-viable package, and them running in their wives and the parents and the children's names companies which supply joints for orthopedics, dialysis fluids for hemodialysis, intraocular companies for ophthalm, I think it's going to vanish. It's going to completely vanish because it's not going to work any longer. But the last point which I'd like to make is a sensible investment in digital technology will give you a much better optimization of your OTs, which is almost 45-50% of your revenue, and better utilization, smart utilization of IPD rooms in your given limited infrastructure without adding extra expense. Thanks.
Anybody wants to comment from the panel?
No, I think what Dr. Bagai is saying is right. It's basically infrastructure utilization and by department, by specialties.
Thank you. Can I ask a question, sir?
Yeah, actually, there are some people waiting. The gentleman behind, yeah.
Hello, it's a question to all in the panel. I am a healthcare entrepreneur, basically non-healthcare background. So one point which I find, and correct me if I'm wrong, peculiar is that most of the initiatives and ideas are, a typical capacity building initiatives, greenfield. Correct me if I'm wrong, home at, healthcare at home initiative also requires, building something ground up. So, but if you see, there are around 545 tertiary care centers in Delhi NCR, and most of them are sitting with underutilized capacity, 20% bed utilization, surgery bed utilization. And if you see the industry, you have yourself mentioned, 1 CR capex per bed, 8 to 10 years, payback period, EBITDA's, kind of dampening. So my take is that if we can think of something which utilizes the unutilized beds, in these centers. So one point which I think I find missing, and correct me if I'm wrong, is how do you define the inventory? For example, whether it is on, let's say, clinical outcomes, whether it is on doctor's efficiency, that data is missing. So maybe a close example could be how Uberization of the taxis had been done. Inventory was defined.
Can you please be brief with your question?
So my take is that if we make it a data-driven exercise, and if we look at actually utilizing of the existing inventory which is spread across, and 90% of that is in the small scale sector. So can we actually and it's a question more from the entrepreneurial side here.
So let me answer that in one line. Between 2010 and 2017, $20 billion has been invested on health technology, right? Both from a patient-centric perspective and also from doctor practices perspective, right? So and this is nothing but unlocking potential and capacities. All that work that is being done today with the digital technology companies in healthcare is predominantly guided by the fact that there is inherent capacity sitting, and how can you sort of maximize it, and therefore what kind of pricing models can you use at the back end to really unlock a lot of this capacity. So that's really what is happening right now.
Okay, so Shobha is asking me to wrap up and with one last question, but if y'all are brief, I'll allow 2 questions. Yep. Only if y'all are very crisp and brief.
No comments, only questions.
Only questions, no comments, as Vishal says.
Okay. So should I?
Yes, please go ahead.
So I am Dr. Harpal Singh Malhotra. I am a senior trade advisor for healthcare from British High Commission. I briefly worked with a startup that's called Nephro Plus, and these guys,
What's your question, sir?
So I have to cite an example and then come to that.
Your question, sir, please. No time for examples. Just a question. If you have a question, otherwise, I can go and.
Okay. So as Dr. Lal said that we need environment. We need to how to solve. The question is. There was a small, problem in that setup. The governments wanted. There was a dialysis, unit which was run, and the government wanted a nephrologist, 24 hours nephrologist, to be present in the dialysis center, which was not possible to, sustain it. So what we are doing to, solve such kind of issues which comes for the startups, to sustain it.
So I think people and talent and startups is. That's where most of the work is being done today, that how do you get the right talent and how do you optimize for that talent. I think having a 24/7 nephrologist and a dialysis center, even the bigger hospitals don't use it, right? Things which can be done by medical techs should be done by medical techs. Things which require specialists should be done by specialists. So that, in short, is the answer.
So the question is there was line and
I need to really wrap up now. Right. Shobha's insisting that we need to. I know there are a lot of questions. We have the panelists. You can take them offline, but we need to stick to the time. I hope all of you understand. Thank you so much, panelists. Thank you for being a wonderful discussion, and thank you for the audience.
Thank you very much. Well done.
A big thank you to all the speakers here, and thank you, Amit, for convening this session.